The Joint State-Federal Relations and International Insurance Issues Committee. Thank you for joining us. Welcome to the committee members. I'm Utah Representative Jim Dunnigan, and I'll be chairing this meeting. I want to recognize our Vice Chair, Representative Brenda Carter from Michigan. May I have a motion to waive the quorum requirements? We have a motion by Representative Carter. Is there a second? We have a second. All in favor say aye. Opposed say no. Motion carries. And now I'm looking for a motion to approve the November 19th, 2022 meeting minutes. Do we have a motion? We have a motion to approve the minutes. A second? We have a second. All in favor say aye. Opposed say no. Motion carries. The minutes are approved. We have a very full agenda today, so we'll get right down to business. We'll start by hearing from Tom Naughton of Maximus. He's going to deliver a presentation on some of the data from the federal and state balance billing independent dispute resolution programs. We'll hold our questions until the end, and then we welcome your questions after Tom is through. Welcome, Tom. Please go ahead. Tom, is your mic on, Tom? Push the button and pull that a little bit closer.
There we go.
Thank you.
In January 2022, the Federal Surprise Billing Arbitration Program was instituted. Cases started to be received and distributed to federal arbitrators in April of 2022. And this morning I'm going to talk to you a few minutes about preliminary data out of the program, some of the challenges and opportunities within that program, and how that existing program has impact on the existing state program and states that do not have existing programs currently. So the volume in that program has been more significant than initially expected. I would say I've been involved in dispute resolution programs for 25 years and have a very good understanding of expected volumes when these programs are instituted. And we were projecting the federal program to have somewhere probably between 20 to 30,000 cases in the first year. And it had received over 100,000 cases in the first 6 months. And although the preliminary data is not out for calendar year Q4 of 23, we're putting it at probably about 150,000 cases for the first calendar year of the program. So that's a large number, and I think what's most important as associated with that number is only about 30% of those cases have been accepted for full arbitration. Right? There's a number of reasons why there's, 77% of the cases aren't accepted for arbitration. I'm going to talk about that a little bit, some of the challenges in the states there. And I think even more importantly, as you break that down, to date, of that 30%, probably only 10% have been fully decided cases wherein an arbitrator says, the award goes to the provider or the award goes to the payer. And to underscore what we believe is the primary pain generator or confusion is right now there are 22 states that have their own surprise billing arbitration program and 28 states plus territories that do not. And within the 22 states that have existing programs, they are labeled as bifurcated states by CCIO and CMS. That means a provider, depending on a specific claim, may go to a state program in the state of Georgia, or he may need or she may need to send that claim to the federal program. And I think the outreach and education to provider groups across the states has not been overly effective. So many providers are submitting cases to the federal program that actually should be going to the state program. That creates a significant amount of delay, stakeholder frustration, and other hurdles to getting the job done and making sure the program is effective. One issue that I think states could take on to assist their providers, of the 22 states that are bifurcated, I believe only 6 of them allow ERISA opt-in, right? So that's the bifurcation, right? If you're not a state-regulated plan, you have to go to the federal program. States such as New Jersey and Virginia allow ERISA plans to opt in to the state arbitration program. Therefore, providers do not have to go the federal pathway. I think states with existing programs would benefit from considering an ERISA opt-in to that program, because it would give the providers one pathway, one door to deal with, one set of rules. And more importantly, state programs, existing state programs, how they're managed and the rules of those arbitrations are different than the federal program. So the bifurcated states right now have providers sort of being treated differently for the same problem, right? So a provider could go to the New Jersey state arbitration program and get one answer, and then go to the federal program for the exact same claim, just an ERISA plan, and get a different answer. So you have a similarly situated problem which has strong potential for getting 2 different answers. That's mostly because there is a, I'll put in quotes, default arbitrator answer on the federal side to go with the average in-network rate of the payer, right? And that is not included in many of the state programs. So a provider going to the state of New Jersey is going to get a much different arbitration through the state program than they do at the federal level. Same with the state of Georgia and all the bifurcated states. For the remaining states that don't have programs, I think considering instituting their own program, which is a zero budget program because the payers pay the cost of the arbitrations and can also pay the cost of setting up the program for the state, would also do a lot to help provider confusion and give them easier access to resolve their disputes with the payers. It would also be very helpful to the payers to really have one program to utilize as opposed to 2 pathways. Another issue that I think is impacting is provider education. So CCIO does not have a formal outreach and education program to providers in the specific states. And I think if they engaged with any of the national IDREs to provide outreach and education, or if the states, particularly the bifurcated states, ask someone, an arbitrator that knows all the programs, to come in and provide education to their hospital associations, to their medical associations, to their specialty groups, and really show them how the nuances of the 2 different programs and their rights and responsibilities under both sets of programs. I think that would go a long way to ease provider confusion and help them in the process. Those are the 2 main pain generators that I really wanted to bring up here. As I said, the data right now is still very preliminary because so few cases have been decided, and I think probably 6 to 9 months from now we will have a better idea of, again, why cases are decided for providers or payers, the reasons for that, et cetera, et cetera. One other thing I wanted to underscore, because this is an important nuance between state programs and the federal program. The federal program has recently decided that if an arbitration case includes an encounter, and that encounter includes half a dozen claims or codes, that each of those codes becomes a separate arbitration. That leads to much more significant expense for providers to engage in the program. It leads for much more significant expense for arbitrators to complete, and it, in my opinion, will only lead to confusion and frustration within the program, right? Historically, an arbitration program, you get one encounter, you go through the codes, You make determinations based on the rules of the arbitration program, and it's one arbitration. To take a 7-code or 12-code encounter and turn that into a 12-code arbitration is going to exponentially increase the cost and time to get work done, and will only, I think, further increase frustration and confusion on the part of providers and payers. So that is the update of significance on this program. And again, I would just underscore, I think states that have existing programs considering allowing opt-in of ERISA plans into the state program would be very helpful. And I think states that don't have programs now to consider standing up their own program would be helpful to their providers and payers within that state. And again, further outreach and education to the provider and payer associations within specific states will only help the program. Thank you very much.
Thank you very much for your report. I think that's very helpful. Let's go to the committee for questions. Oh, I have a couple. Did you say that 30% of the cases are accepted?
Correct.
What happens to the other 70%? Is the initial resolution, is that just what ends up happening?
The other 70% may be rejected because they should have gone through an existing state program. They may be put on hold because CMS is not sure how to handle that program, handle that specific type of case. Or there is information that is required to complete the arbitration that has not been submitted. Those are the main reasons for rejecting cases.
And I think you said 70% of the cases that are going to the feds should go to the states. Did I get that off?
No, we don't have that data yet.
But there are a lot.
But there's a fair amount of yeah, I don't know that it's 70%, but I would say it's at least 40 to 50%.
So when that happens, then it's just sent back to the states? Or
Well,
is it just rejected?
It's rejected, and the provider now has to go through the process again of going through the state.
Is that an additional fee?
It could be, depending on the state, yes.
Is it seen, do you have enough data to see if it's seen by either providers or the insurance plans if state or the feds are considered to be more friendly to their cause?
We don't have enough data from the federal program yet to do a good comparison right now. I would say, anecdotally, the federal program likely leans towards payers at this point.
Okay.
But I would also, and these programs often will start, there's a very good example from the state of New Jersey, which has had arbitration programs since 2007. And, in 2007, the payers were here and the providers were here. And we actually did a fair amount we probably did 5,000 cases that year. And providers were winning significantly amount of the time. And so in 2008, we did 10,000 cases. In 2009, we did 12, and then we did 15,000 in 2010, which for the state of New Jersey is a significant number of arbitrations. And what happened after that was the payers and providers started coming together, so that in 2011, we were down to 8,000 cases and down, winnowing down to the point where starting in 2015 and going forward, you're really seeing cases where folks just always are going to arbitrate every case no matter what, right? Or it's a new code, a new case of impression. But the volumes have gone down significantly in the New Jersey programs and have stayed right around south of 5,000 since 2015. So a year from now, we should have data, and you should actually start to see middle ground starting to be achieved. And it's usually, based on our experience where we're in, been doing this work across states for many years, usually takes about 3 to 5 years to get to the middle ground of what we would call success, where the arbitrations are, again, people that always want to arbitrate or it's cases of first impression.
Thank you. My last question, if you were to put on your crystal ball, if you had 150,000 cases this year, in the first year? What will you have the second year? It doesn't have to be exact, just within 500 or 600.
Our projections for the next year are over 200,000 cases.
80?
I'm sorry?
What would you say?
Over 200,000.
Over 200. Wow.
Yep.
Okay. Thank you. Any committee questions? We have one. Go ahead.
Yeah, Tom, I'm from Ohio. And, Ohio got a real good solution, but, how we got that solution is both the plans and the providers got together with almost the Department of Insurance being a referee. I think we all got involved that we did not want too many cases arbitrated, because I agree with you. And so, but I don't know if I agree with some of your statements of trying to get everything together, because you're going to have certain states that are going to be extremely more liberal than conservative states. And so it's a difficult scenario how to do that. But so my question to you, though, is how's Ohio doing? Is it too early to tell? Because we didn't want too many cases, but we wanted to be fair. But the solution, the providers and the plans played a major role. You had both sides play in the solution.
Oh, yeah, they did. We were definitely involved in some of those negotiations and discussions. So for Ohio, I would say it's too early to tell, but I would also say you achieved your goal of not getting too many arbitrations.
Okay, thank you. Thank you.
Thank you. Any other questions? I see none. Tom, thank you very much.
Thank you
Appreciate
very
that
much.
helpful information. Next on our agenda is a presentation on preventive services, which will focus on how and why certain services meet that term. We'll discuss a case titled Braidwood Management versus Becerra that deals with preventive services and has some important implications for us as policymakers and for our constituents. In your binders on page 29 is some background material that you may wish to look at for this presentation. It's also on the conference app and the website. On the app and the website, but not in your binders, is the actual opinion on the case if you're interested. Today, our panelists consist of Justin Giovanelli of the Center on Health Insurance Reforms at Georgetown University, Emily Carroll of the American Medical Association, and Greg Baylor of the Alliance Defending Freedom. We'll hold our questions until all of our speakers are finished. We'll hear first from Justin. Justin, please go ahead. And grab that microphone and get it close to your tonsils.
Thank you, Mr. Chair. Is this sufficiently close to my mouth?
That's good.
Great. Thanks so much for having me. My name is Justin Giovanelli. I'm a research professor at Georgetown University's Center on Health Insurance Reforms. Much of our work is understanding state and federal regulation of private health insurance. Certainly a significant chunk of that is trying to understand the implementation of the Affordable Care Act and how states have responded to that federal law. And there's a bit about us. So what I hoped to talk to you about today, as the chairman indicated, is the Federal Preventive Services Protection, which was enacted with the ACA back in 2010, give you an overview of that protection from a legal standpoint, and talk about a recent lawsuit that is challenging that protection, and talk about an option or two that you all as state legislators may have depending on the outcome of this case. So I think you're going to hear a bit more about some of the particular services that have been classified as preventive under the statute and perhaps about other aspects of the litigation, but I'll try to provide an overview of all of that. So Federal Preventive Services Protection requires coverage of many preventive services without cost sharing, and that last part is really important, right? There's a lot of evidence to suggest that if there is imposition of cost sharing on even these high value services that are covered now by health insurance companies, that individuals don't get those services if they have to pay out of pocket often. So this protection provides access to those services without cost sharing. It applies very broadly to almost all private health insurance. So all of the fully insured markets that you all regulate as well as ERISA-regulated employer benefit group health plans. So what is actually required to be covered? This is important to get an understanding of the litigation that I'm going to talk about in a second and to get a sense of what kind of services we're talking about. So what the statute does, what Congress did, was instead of list all of the preventive services that seemed to be a good idea in 2010, what the statute did instead was identify 3 different expert bodies: the U.S. Preventive Services Task Force, the Advisory Committee on Immunization Practices, and the Health Resources and Services Administration, and indicate with respect to each of them that certain types of services recommended by these expert bodies would need to be covered without cost sharing. And so you can see effectively the language from the statute there at the bullet points. So for example, all items and services with an A or B rating from the U.S. PSTF. There actually is more language there with respect to it needing to be evidence-based items and services, but you get the general idea. So this has been the framework that everyone's operated under for the past dozen or so years, and I'll talk a little bit about how many folks are covered by plans that have this protection in a little bit. What we have more recently is this litigation challenging aspects of that, or really the entire protection that I've described, and so that's the Braidwood Management case. This is a lawsuit in the Northern District of Texas. There are a couple of elements to it. One involves a comparatively more narrow claim under federal law, under the Religious Freedom Restoration Act. That challenge at this point is primarily about coverage of anti-HIV medication. I'm not going to really get into that element of the case today. I'm happy to answer questions about it if you'd like, but I'm going to focus more on the broader constitutional challenges to the provision. And this is really important. We have here a challenge based on the U.S. Constitution to the power of the U.S. Congress. This is really a federal lawsuit without implications for the authority of all of you to regulate health insurance under state law. It's obviously a very significant piece of litigation, but it's really all about federal power under the U.S. Constitution. There are 2 main elements of the constitutional challenge. I'm going to just outline briefly here. Happy to talk about more detail if you'd like. So the first is grounded in the Appointments Clause of the Constitution. The second has to do with something called the non-delegation doctrine. The Appointments Clause argument from the plaintiffs, and the plaintiffs in this case are a couple of businesses, a couple of individuals who object to this provision of the law. The argument here is that the individuals who sit on these expert bodies are, in a legal sense, they're officers of the United States, and so that they are officers, and because they are officers, they've got to be appointed in a certain way that complies with the Constitution, and the argument is that they have not been. The second argument, the non-delegation doctrine argument, this is a doctrine that has not gotten much use or attention in recent years. The Supreme Court last used it to strike down a law back in the early New Deal years in the 1930s, but there is certainly an indication from the current Supreme Court that there is an interest in perhaps revitalizing this doctrine. And the gist of it is that while Congress can certainly delegate authority in certain circumstances in federal law, when they do that, they have to provide an intelligible principle for how that authority should be exercised. And the argument here from plaintiffs is that when Congress said that these expert bodies will identify recommendations that have to be covered, they were delegating authority to the bodies without any sort of guidance for how that should be done. So that's the legal challenge. We have an opinion on the merits in the district court. This was issued back in September of last year. It's a merits decision. It's not a decision on the remedy, which is really important. So on the merits, what we have is, in some fashion, a split decision, but I will emphasize here this is really round one to really start to mix my boxing or whatever metaphors here. So the decision from the district court was to agree with the plaintiffs on their Appointments Clause challenge as to the USPSTF recommendations. So the court concluded that there was a violation there. Really, it concluded that all of these experts should have been count as officers of the United States and were not properly appointed. But the two of the three bodies, their decisions are in effect ratified by HHS, and so that cures any constitutional problem. USPSTF is different. Its decisions cannot be ratified, said the court, and so we have a violation there. The court also agreed with the plaintiffs on the RFRA challenge. Again, I'm not going to really touch on that at the moment, but there's that there as well. The non-delegation claim, the court rejected, primarily because of existing precedent on this issue. So as I indicated, this is a type of approach to federal administrative law that we haven't seen much of in many years, and there is binding Fifth Circuit precedent where the Texas court sits that easily disposed of that sort of challenge. But the court recognized, which is absolutely correct, that the current Supreme Court might think differently. And so while the government prevailed on this claim in the district court, we may see more of it as the case goes up on appeal. This case will definitely go up on appeal. It will definitely go to the Fifth Circuit. It very well may wind up in the Supreme Court in years to come. A word on the remedy, and I guess more than a word, what I'm going to focus on the rest of my time here. So the court decided on the merits, but it didn't decide on about what should happen because of this Appointments Clause violation. That's been briefed by the parties. The court could issue a decision any time. The plaintiffs have asked for a universal remedy. Basically, they want the requirement to cover the USPSTF recommendations to be struck down nationwide, so that was a requirement that would no longer be in effect in any state. So we don't know if the district court will agree with that approach, but there is some reason to believe in the merits opinion that it might. So what is currently at issue is more than 50 preventive services that are recommended by the USPSTF and that must be covered. Screenings for a range of cancers, for depression, for high blood pressure, preeclampsia screening, folic acid for pregnant women, down the line. These are services that are currently required to be covered. Plaintiffs have asked that they not be required to be covered and have asked the district court to issue a nationwide ruling. So that's where we stand in the district court. On appeal, again, everything is really on the table. I think there's certainly reason to believe that the higher courts could actually issue a broader ruling in favor of the plaintiffs. And so really at that point, you're talking about more than 100 preventive services potentially at issue, affecting a lot of Americans. And in particular, and I apologize here for a couple of things, including the small print on the big screen. I try to provide some state-specific estimates of folks who might be impacted by this, trying to pick out all of your states. I apologize very much if I excluded anyone. That is my fault, and I'm happy to give you that data if you'd like to see it. But these are the numbers of people in states that would be affected by a ruling making that this coverage no longer required. We're talking a lot of people. So what might states do if they are so inclined? Well, step one is to take a look at current law and see what is required under current law. So, of course, as you know, there are a fair number in virtually all states of state-required benefits. In general, though, these are fairly patchwork, accrued over the years. They are certainly not as comprehensive as the coverage framework we've worked with for the last dozen or so years under the federal protection. Importantly also, in general, you know, these state laws do not speak to cost sharing. They do not require preventive services to be covered without cost sharing, unlike the current federal framework. So depending on what the status of your laws are and your interest, certainly one thing that states can do is require the fully insured markets to cover the services that are currently required to be covered under federal law. So there is, again, as I indicated at the outset, the lawsuit's all about federal law. It's not about state law. It's not about state power to regulate. States certainly have authority to enact laws that look just like the federal provision if you're so inclined. There are more than a dozen states that have something like that on the books already for their individual markets, and certainly this could be done in other places. As I wrap up here, I would say, of course, there's a major drawback to this particular solution, and that's simply, of course, that While you all have regulatory authority over fully insured plans, you do not over ERISA-regulated federally regulated plans. And so the large numbers of people affected by a decision here, many of whom you can't actually, unfortunately, help if you're inclined. But for fully insured markets, there is state authority, and certainly you can act in this way if you would like. So thanks so much for your time, and I'm happy to answer any questions you might have.
Thank you very much, Justin, and we'll take the questions at the end. Next, we'll hear from Emily Carroll of the American Medical Association. Welcome, Emily.
Thank you. Thanks so much for having me. Can you hear me all right?
Yes.
Great. My name is Emily Carroll. I'm with the American Medical Association. The AMA is the largest professional association of physicians, residents, and medical students in the U.S. We have members practicing in every state and every specialty. We very much appreciate the opportunity to be here to discuss the importance of preventive health care and our concerns about an overly broad remedy in the Becerra case, or in the Braidwood v. Becerra case, that could jeopardize the coverage of preventive services to millions of Americans. Physicians certainly know the value of preventive care when it comes to helping their patients live long, healthy lives. Ensuring that patients can receive services without financial barriers is of the utmost importance to our members. Preventive care can mean the difference between kicking a smoking habit or living with a heightened risk of dozens of illnesses. It's the difference between taking a statin or suffering a heart attack. It's the difference between catching a patient's cancer early or catching it after it's too late. Identifying and treating conditions before they worsen or before they present at all yields better outcomes for patients and saves money for the overall healthcare system. Physicians recognize they have an obligation to ensure that their patients and the public as a whole receive medically indicated preventive services. Principle 7 of the AMA's Principles of Medical Ethics state, a physician shall recognize a responsibility to participate in activities contributing to the improvement of the community and the betterment of public health. And Opinion 811 of the Code specifies that while a physician's role tends to focus on diagnosing and treating illness once it occurs, physicians also have a professional commitment to prevent disease and promote health and well-being for the patients and the communities. This is because preventive care first and foremost saves and improves the quality of lives. There is an extensive body of evidence demonstrating how preventive care can help patients live long, healthy lives. Such services include prevention, early detection, and treatment of potentially fatal medical conditions and chronic diseases, as well as services aimed at encouraging people to live healthy lifestyles. These services can help identify diseases at earlier stages when they are more treatable or may reduce a person's risk for developing a disease. For example, according to the American Cancer Society, cervical cancer incidence and mortality rates have decreased by almost 50% in the past 3 decades, and this is attributed to screening, which can detect both cervical cancers at an early stage and precancerous lesions. Screening can identify people at risk for developing type 1 diabetes before they even become symptomatic. And screening in pediatric populations has shown to lower HbA1cs and shorten hospital stays at diagnosis. Smoking cessation reduces the risk of 12 different cancers and can help improve health outcomes after a cancer diagnosis. It also reduces risk and improves health outcomes after a diagnosis as to cardiovascular diseases, stroke, aneurysms, respiratory diseases, asthma, pregnancy, and reproductive health. And late entry into prenatal care or no prenatal care at all is known to contribute to poorer birth outcomes, especially an increase in low birth weight and preterm babies. Ensuring access to preventive care also saves money within the healthcare system. By reducing the amount of undiagnosed or untreated conditions, preventive care reduces costs through less invasive or complex treatments. Put simply, cancer is easier and cheaper to treat at the outset than after it has metastasized. HIV is less costly to prevent than treat. Prediabetes screening is cheaper than treating diabetes. A flu shot is cheaper than caring for a patient in the hospital with the flu. But despite all the benefits, it's often difficult for physicians to get patients to access preventive services, and this can be particularly true for minoritized and marginalized communities. For example, an estimated 1.2 million Americans at risk of HIV infection should be taking PrEP, according to the CDC, but only 25% are doing so, and use among Black and Hispanic patients is especially low. Studies have shown that out-of-pocket payments can be a barrier to use of recommended preventive services, and reductions in cost sharing were found to be associated with an increased use. Congress recognized this when it passed the ACA, and it recognized the role of health plans and payers in improving access to preventive care. In enacting the ACA, Congress sought to guarantee access to services like these regardless of financial constraints, and I want to stress how important this access is to the AMA and our physician members. Congress was really careful to make sure that insurers would be required to cover only effective, high-value services through evidence-based recommendation. And just to be clear, one more time, as to the types of services we are talking about. We're talking about screenings, genetic assessments, risk-reducing medications, and behavioral counseling for various cancers, including breast, colorectal, lung, skin, and various forms of cancers of the female reproductive system. We're talking about preventive services for pregnant people or in those who have recently given birth, including screening for aspirin use in those with high risk for preeclampsia, interventions to support breastfeeding, screenings for sexually transmitted diseases, folic acid supplements for neural tube defects, gestational diabetes screening, preventive medications for newborns, and blood testing. We're also talking about services for populations at high risk for certain conditions, including aneurysm screening in older men who have a history of smoking, cardiovascular disease screening, including among at-risk populations, tuberculosis screening, screening for osteoporosis in older women, screening for diabetes and type 2 diabetes in adults who are overweight, and statin use in adults with cardiovascular risk factors. And we're also talking about preventive mental health screenings, including anxiety, depression, and suicide risk screenings in children and adults. Removal of guaranteed access to these services could have devastating effects. As Justin mentioned, currently 151.6 million people have private health care coverage that covers preventive services with zero cost sharing. A literature review in 2022 found that 35 separate studies determined the majority of findings conclude that cost-sharing elimination led to an increase in utilization for select preventative services. Literature also suggests that this is particularly true for low socioeconomic groups and those who experience the greatest financial barriers to care. Additionally, the availability of no-cost preventive care has improved utilization and health outcomes among populations that have been historically subject to discrimination. If the court were to apply a broad remedy in the Braidwood case, we fear a return to ACA or pre-ACA regulatory regimes where insurers could charge patients for preventive care at their will. It's likely health plans and employers would impose deductibles and copays for some or all of the service recommended by the task force. Imposing a copay or high deductible to access preventive care for patients will deter some, and in particular those of limited means, from scheduling such care. And gutting this requirement will significantly set us back as a society in terms of improving health outcomes in marginalized communities. Moreover, we'll all be affected by the confusion that emerges. For the first time in 10 years, we will have to scrutinize insurance plans to determine what preventive care they cover and at what out-of-pocket costs. And we will likely see a race to the bottom in terms of insurance. Insurers and payers will alter their plans in ways to distort the functioning of the system. And many insurers will likely design their preventive benefits to attract healthier customers, forcing other insurers to follow suit to compete. Ultimately, if the court invalidates the task force recommendations nationwide, physicians will be left in a really tough situation. They'll struggle to encourage their patients to accept services they know will save their lives, but they'll see many of their patients, some of their most vulnerable patients, turn down medically indicated care because of financial barriers. As we wait to see what the court decides in terms of the remedy, we are reminded that remedies are about equities, and those equities here include the ability of patients to continue receiving no-cost preventive care as they have for over a decade. The past 10 years have shown the benefits of no-cost preventive coverage, and that's why the AMA and a number of other medical societies have asked the court to consider this before ordering a remedy that could upset this process. So I thank you for your time.
Thank you very much, Emily. Now we'll hear from Greg Baylor of the Alliance Defending Freedom.
Thank you, Mr. Chairman and members of the committee. Appreciate the opportunity to be here. I work for an organization called Alliance Defending Freedom. We're involved in many religious liberty cases, including ones.
Greg, will you pull that mic just a little bit closer?
Sure.
Just grab that baby.
There we
There
go.
you go. Thank you.
Tonsil touching. I work for an organization called Alliance Defending Freedom. I serve as senior counsel there and director of the Center for Religious Schools. Alliance Defending Freedom has been and continues to be involved in many disputes involving the application of insurance coverage mandates that violate the religious freedom of our clients, including the Hobby Lobby case that made it to the Supreme Court and to the Zubik case, which subsequently made it to the Supreme Court. Given that involvement and experience, it'll be no surprise to you that I wanted to focus on the Religious Freedom Restoration Act aspect of the case. And I think it's helpful perhaps to put the Religious Freedom Restoration Act into a little bit of context. Religious liberty in general, we lawyers like to think that there's two categories of legal rules that violate religious liberty or at least infringe upon religious exercise. There are those rules, which are thankfully pretty rare, that target religious exercise for particularly adverse treatment. And then there's the other kind that's more complicated. It's a rule that sort of applies to everybody, but happens to sort of incidentally impose a burden, even a serious, substantial burden upon a religious claimant. And that division matters because judges want to know what tests they should apply, how much scrutiny should they apply to the government's action in a particular case. And there's been a debate about this, about what do you do with a law that wasn't intended to go after religious exercise, but nonetheless imposes a burden as significant as if the law were targeted at religious exercise exclusively. And for a time, the U.S. Supreme Court, when it was interpreting the First Amendment's free exercise clause, said, look, we don't care where the burden comes from. The burden is the burden. And therefore, in order to uphold the spirit and the letter of the First Amendment, we need to apply what's called strict scrutiny to this burden. So under strict scrutiny, the court will ask the claimant, tell us how bad this is for you. How substantial is the burden on the exercise of your religion? And if the claimant is able to prove to the court that that burden is significant enough, the court will turn to the government and say, look, what are you trying to accomplish here? How important is your interest? Is it compelling? And then they'll ask, is there any other way you can do this? Is the means that you've chosen to pursue your objective the least restrictive one? Eventually, the Supreme Court changed its mind about this and said, you know what, if it's not targeting, if it's a generally applicable, facially neutral rule, we're going to no longer apply strict scrutiny. There was great uproar on all sides of the spectrums, political, ideological, religious, and that resulted in the passage of the Religious Freedom Restoration Act, which restored strict scrutiny, this test that the government is hard for the government to win, to cases not involving not just targeting of religious exercise, but into incidental burdens on religious exercise of generally applicable and facially neutral laws. So that statute passed in 1993 and resulted in a number of victories for religious claimants. Unfortunately, at least from my perspective, about 4 years later, the Supreme Court said, Congress, you had the authority to restrain the federal government with this Religious Freedom Restoration Act, but you do not have the authority to restrain y'all, to restrain state and local governments. So I think this goes to Justin's point about the impact of this case on the state system. A RFRA conclusion in favor of the plaintiffs in this case is what we had, doesn't necessarily control the power of state legislatures and state administrative agencies to enforce insurance coverage mandates against religious claimants. So that's the backdrop. Let's move to the litigation over mandates in general. I think the debate in this area started when states themselves started adopting contraceptive coverage mandates well in advance of the ACA. And some of the states had robust religious exemptions for those religious entities that didn't want to include that in their employee health plans for religious reasons, for reasons of conscience. But some states had very narrow exemptions, and that necessitated litigation in New York, litigation in California, both by Catholic charities that did not want to cover contraceptives and sterilization. And they lost those cases because the tests the courts were using was not strong enough. But then go fast forward to when the federal government adopts a contraceptive mandate via the ACA by HHS HRSA. Again, an insufficient religious exemption, which prompted literally hundreds of lawsuits challenging the contraceptive mandate. Many of the plaintiffs challenged only the abortifacient contraceptives, the ones that can and do sometimes interfere with implantation of the young human being in the uterine wall. Many of the Roman Catholic challengers challenged the whole thing. They didn't want to be sort of complicit in the provision of any contraceptives. And their legal claim to challenge this was the Religious Freedom Restoration Act, which, as you recall, requires the claimant to say, this is really bad for my religion. It's making me do something that's against my religion. I'm offending God by engaging in the behavior that this statute or administrative regulation forces me to do. So the courts in these cases turned to the government and said, okay, what are you trying to accomplish here, and is there some other way you can do it? And Hobby Lobby prevailed in its case because there was some other way to do it. The HHS had set up a mechanism by which religious nonprofits could comply, but they didn't offer that alternative mechanism to Hobby Lobby and other for-profit entities owned by people of faith. So they prevailed. And then the nonprofits prevailed as well on sort of a complicated reasoning, and eventually because the rules were changed when President Trump came into office in 2017. So that's the background to Braidwood. Let's talk a little bit about Braidwood management. I'm not going to cover ground that Justin already did. What is it that they objected to on religious grounds? Well, when the case got to the stage that we're talking about right now, the remaining objection was to the pre-exposure prophylactic medication, the PrEP medication. And the plaintiffs argued they observed that they believe that homosexual behavior is contrary to their religion. And then they said, look, if we include the PrEP medication in our employee health plans, we're going to be facilitating behavior that we think is inappropriate, immoral, or sinful. And the court agreed that this requirement imposed a substantial burden on their religious exercise for purposes of the Religious Freedom Restoration Act. And this was not hard and not controversial, at least as a legal matter, because Hobby Lobby had already paved the road for this. I mean, Hobby Lobby, if it stands for anything, it stands for the proposition that you make someone include in their health plan an item that violates their conscience, that's a substantial burden. So the court turned to HHS and the other defendants and said, okay, what is it that you're trying to achieve here? What's your interest? How compelling is it? And of course, the interest is reducing the incidence of HIV, the spread of HIV, and the resultant health problems and deaths that occur when that happens. And the plaintiff said, hey, we don't disagree that that's a compelling interest. But you're asking the question at the wrong level of specificity. The question is not whether the interest is compelling sort of in the abstract, but the question is whether it's compelling and necessary with respect to this plaintiff. So you don't ask the question, what would it be like if this mandate didn't exist? The real question is, what would it be like if this mandate didn't apply to this particular claimant? And obviously the consequences are much lower when you're talking about one employer. As I understand it, the employer making this claim had about 80 employees. So they didn't. So they concluded. The court concluded that this violates RFRA. There's no other way to comply. There's no other mechanism that they've offered to Braidwood to comply with this. And there are less restrictive means by which they could accomplish this purpose. Throughout the HHS mandate litigation, one of the things that the plaintiffs argued was like, you know what, there's another way you guys can do this. You can actually pay for it yourself. And interestingly enough, the Biden administration, in its proposed rule about the contraceptive mandate, in which they're proposing to replace the Trump rules, has proposed precisely that, so that women who work for employers who have objected, who've opted out, who've been given exemption under the law, they have an opportunity to get the coverage cost-free to them through the federal government itself paying for it, not through the mechanism of the rejecting employer's health plan and at the health plan's expense. So what does this mean in Braidwood? Who won? what's the remedy going to look like? Well, they haven't said yet exactly what the remedy for the RFRA violation will be, but I have no doubt in my mind that the only entity that will be exempted because of this decision from the PrEP coverage mandate is the company itself. Now, certainly other employers can file their own lawsuits and use that decision as a precedent, but the Braidwood management case itself does not confer on anyone else the right to opt out of this requirement. So what are the implications for the states? As Emily and Justin both mentioned, this means that if this stands up on appeal, there will be a number of women who don't, and others, given the scope of the preventive services that are required to be covered, they won't have that protection or that mandate of federal law, and it's presumably the role for the states to step in and provide that themselves. One issue about that, and that's the last thing that I'm going to say, is just because a state-level mandate can't be attacked based on the Religious Freedom Restoration Act, because again, it doesn't apply to state and local governments, doesn't mean that it can't be challenged under comparable statutes and constitutional provisions in state law. So if a state were to adopt a sort of PrEP coverage mandate, there's a significant possibility that some employers would turn around and file litigation not under the Religious Freedom Restoration Act, but under state statutes that provide for strict scrutiny and under state constitutional provisions that provide for strict scrutiny. So that brings me to the close of my prepared remarks, and I'd be delighted to answer any questions you may have.
Thank you very much, Greg. So we want to thank all three of our panelists. Now we'll go to the committee for questions. First, we'll start with the Representative McFall.
Thank you very much. I appreciate it. This is my first time here, so I'm just understanding how this works, but thank you very much. I have a question, and I can't read your name from here. I believe it was Justin. You had mentioned that there were states that had done this. Which states were those?
Well, by our count, there are something like 15 or so states that have provisions actually that they had enacted before this litigation, frankly, in response to other federal challenges to the Affordable Care Act, that in some fashion they take slightly different forms, but in some fashion basically mirror the language of the federal statute. And so certainly state lawyers should always take a look at everything you're considering enacting, but to our mind, these are provisions that don't in any way rely on the federal protection continuing and do not implicate any of the federal constitutional or statutory issues that are raised in Braidwood.
Can you tell me what some of those states were, or are, I should say?
Off the top of my head, that would be a fun challenge. New York.
Because I'm looking for model legislation.
Yes. Well, I'm happy to provide you some of that. So I believe New York has such a statute. I believe Oregon is making slight changes to theirs, but Oregon does. I believe Washington State, New Mexico. We have a publication on this with a fancy map, or not so fancy, but it has the answers you're looking for, so I can get that to you.
I appreciate that. Thank you very much.
Sure.
Thank you. Just a reminder for the first-time question, there's a $50 fee. It's remitted to the chair, so I'm going to ask my vice chair to collect those after. Okay, next we'll hear from Representative Stone.
Thank you. I'm directing this to Mr. Baylor, but anyone on the panel is open to it. Has anyone approached this issue from the position that they're having an individual's religious beliefs imposed upon them and that their individual rights are being violated because someone is stripping them of access?
Well, I think the argument has been made kind of in the court of public opinion, but it's not been made in the course of a legal case. And it's not a case that would succeed because the Religious Freedom Restoration Act, the Free Exercise Clause, state analogs to those things, they don't restrain non-governmental individuals. There's some exceptions. But for the most part, you can't sue someone else who's a non-governmental entity for violating the Religious Freedom Restoration Act or the Free Exercise Clause. So, but, you know, in a kind of conversational sense or in discussions in the media and in other public fora, people have said, yes, you're imposing your religion on me. So you're right about that, but it's not a valid legal argument.
Thank you. Representative Mayfield.
Thank you so much. So, Justin, I just had a couple questions. I'm over here. Over here. Justin. Hi. Hi. How are you? All right. So I also wanted to get that list of states that are already doing this. I know that Illinois has piecemealed some of this because we do offer the PrEP and other preventive services, but I would like a comprehensive list. And then for your recommendation, asking that there be parity between, what was your statement? I pulled up your slide here. Hold on. Group market carriers and individual market carriers. You're saying that they need to require the same benefits without cost sharing?
So what I was suggesting is that under the current framework, so the federal protection applies to all fully insured plans, individual and group market plans, and it also applies to ERISA-regulated plans over which you all lack authority. But over the fully insured plans that you can regulate, there is certainly, you would have authority to pass this requirement in the individual market, but then also for coverage that is offered to small and large businesses too.
Okay. And these states that have already implemented, this is what they've done, or did they implement something different?
So our investigation looked at the individual market specifically, and so the 15 or so states, that number that I'm throwing around is with respect to the individual market. I know that some of those states, the protection is broader into the group markets. I can't say for sure how many that's the case for.
Okay, and then my next question is, how does offering preventive maintenance impede somebody's religious rights?
That's probably for you.
So in most faiths, they have moral assessments about what's religiously permissible and not permissible. And a lot of the time, you're talking about an action that the person themselves believes that they may not do. But there's another doctrine, both in religious and non-religious philosophy, about being complicit in somebody else's behavior. And I think that is what we're talking about when we're talking about contraceptive mandate, when we're talking about a PrEP mandate and all the rest. It's not so much that the person is being compelled to do the thing ultimately that they object to, but they're being required to facilitate it, to play a role an indispensable role in the causal chain. And I think it's a kind of a well-settled principle of ethical philosophy that can be, that's a legitimate kind of thinking about what's morally permissible and what's not. It's not limited to the things that you do, but it includes the things that you're sort of complicit in by the things that you add to the process. And that is, as a legal matter, it's been accepted by courts that you can have a valid religious freedom claim because you're being compelled to be complicit in something that you believe it to be against your religion.
So is this claim on the individual or is this claim on the health carrier?
Could you clarify your question?
Yes. So you're saying, this religious exemption, are you saying that the health insurance carrier that is being mandated to offer the preventive maintenance has a religious objection as opposed to an individual that is receiving the health care?
Well, the plan sponsors are typically the plaintiffs in cases challenging these. So it's the employer or the university that has a student health plan. They are the challenger, right? Because at least in the ACA case, the mandate applies both to carriers and to TPAs and to the plan sponsor. Most insurance companies don't have, or TPAs don't have a religious objection to providing any of this, but there are some. Guidestone, which works with the Southern Baptist Convention, they were a plaintiff in the HHS mandate litigation, not because they were a plan sponsor and objected because of that, but they were actually the plan provider or the TPA. So both kinds can assert, both kinds of plaintiffs, as it were, can assert these claims.
So these plan sponsors, aren't they corporations?
Yes.
Corporations are not exactly people.
Corporations,
They're comprised of people, but they're not people.
yeah, no, of course, there's a distinction between corporations and natural persons. But this was actually an important part of the Hobby Lobby case, right? The Religious Freedom Restoration Act confers religious freedom protection on persons. And of course, the definition of person in federal statutory law does include non-natural entities like corporations, partnerships, and all the rest. And the government, the federal government, in defending these claims, these challenges to the HHS contraceptive mandate, its first argument was Hobby Lobby doesn't have a right to claim the protection of the Religious Freedom Restoration Act. And some of those arguments were sort of legal, more rooted in the text, and some of them were more like, how does a company have a religious belief, right? And, well, companies have positions on questions even if they're not natural people. And the conclusion was the owners of the company, the Green family in the case of Hobby Lobby, themselves had religious company, and they were the leaders of the organization and could decide for it what the entity's religious views are. So it's a question that got asked in the Supreme Court, but it's been settled.
Okay, thank you.
Welcome.
Thank you. Representative Rogers.
Thank you. I'm a state representative from Michigan, and my first question is for Mr. Baylor. So you had just mentioned the ethical philosophy and the complicit behavior. And so my question is, what about infants? What about situations where the person being affected potentially by HIV had no decision making in that? So going down the road of the argument saying that the religious institutions don't want to cover HIV medications because of this complicit behavior, what about the infant that had no choice in the matter that contracts HIV from his or her mother in the womb?
Sure. Almost every religious liberty claim involves a balancing of competing interests. And, you know, the strict scrutiny test that I laid out that is applicable under RFRA and many state analogs takes account for interests, you know, all the interests involved in the case. So the first interest they focus on, again, is whether this imposes a burden on the religious exercise of the entity that doesn't want to include something in its health plan. And suppose that they satisfy that. You move on, and then the government identifies its interest. And in the analysis of that interest, you do consider the impact on third parties. That's just part of the, you know, how much will giving this entity an exemption undermine the goal that the government is trying to pursue? And you can certainly raise evidence about what kind of impact it would have on third parties. That's why we argued in the contraceptive mandate cases, not that individuals should never get this coverage, but that the company itself or the individual, him or herself, wouldn't be complicit in providing it. And we recommended that the government itself pay for that so that the ultimate beneficiaries of the plan would get what they want, but just leave us out of it. And again, the Biden administration has belatedly embraced that view in the current notice of proposed rulemaking on the HHS contraceptive mandate. So it's a valid consideration. It's taken account in the test. And the Biden administration is doing, you know, probably, at least from their perspective, the right thing to make sure that people get the coverage they want.
Thank you. And if I can have a quick follow-up, I just want to thank Emily Carroll for her comments from AMA. I think covering preventive care is not only the moral and right thing to do, but it's oftentimes the fiscally conservative thing to do, as she pointed out. So for all the insurers in the room, if this court case does go in a different direction, I implore you to do the right thing and step up and do preventative coverage. Thank you.
Thank you. So Justin, Emily, Greg, thank you very much. It was informative. Appreciate your being with us. Last on our agenda is a presentation on the preparation for and implications of the end of the public health emergency. In your binders on page 39 is some background material that you may wish to look at. It's also on the conference app and website. With us here today, we have Miranda Motter of America's Health Insurance Plans. Miranda, please go ahead.
Thank you. Thank you very much for the opportunity to spend a couple of minutes with you this morning. I am Miranda Motter. I am the Senior Vice President of Affairs and Policy for AHIP, who is the National Trade Association representing health insurance plans that provides coverage to individuals, to employers, to Medicaid agencies and states, and Medicare all throughout this country. So thank you for the opportunity. I want to spend just a couple of minutes revisiting, I know, a couple of issues that we have previously spoken about. The first is Medicaid redeterminations and some legislation that was passed at the end of the year, which has now decoupled one of the major requirements as part of Medicaid redeterminations from the end of the public health emergency. And since that time, we also now have an announcement from the administration about when the COVID national emergency and the public health emergency will end. So really just wanted to provide a couple of updates relative to those announcements, some key dates, and then certainly a series of resources, hopefully that you will find helpful, some links included in this presentation. With that, I will start with the Medicaid redeterminations and a piece of legislation that Congress passed at the end of the year called the Consolidation Appropriations Act of 2023. Many of you are very aware of the work that sits in front of the states with the decoupling of the Medicaid redetermination processes from the maintenance of eligibility requirements. The most recent numbers I think I saw this week out of CMS indicates that individuals that are currently receiving health insurance coverage under Medicaid has reached about 93 million individuals all across this country. I know many of your Medicaid directors and staffs and governor's office, health policy staff, and many of you and your staff and insurance commissioners in this room have been very focused on this issue. There is a number of individuals that will now, with this decoupling, be sitting in a situation where they will need to go through an annual redetermination process that had paused during the public health emergency. So let me just start at the top of the slide, this decoupling. So originally, the Medicaid redetermination maintenance of eligibility requirement, which essentially was in the Families First Act that Congress passed, Congress provided states an additional FMAP percentage, a 6.2 percentage, if they did not terminate anybody's Medicaid eligibility throughout the public health emergency. Prior to the passage of this Consolidation Appropriations Act, that was all going to be tied to the end of the public health emergency. This legislation now gives us a date certain. I think the last time we talked, there was a lot of uncertainty about when the public health emergency was going to end. And so while a lot of work was being done in the states, it wasn't quite clear when all of that needed to start. We now have a date, March the 31st. As a result, and as laid out in that statute, the FMAP, that additional 6.2%, which sits on top of the FMAP that each one of your states have as it relates to your Medicaid agencies, will begin to decrease. So that decreasing, it will be 6.2% through the 31st of March. So beginning on April 1st, states may begin to terminate individuals who no longer are eligible for Medicaid. And you'll see there the additional leveling down of the FMAP as we get to December the 31st of 2023. The other two things that passed as part of that federal legislation are there are state requirements as it relates to how states will conduct their redeterminations. They must comply with eligibility requirements. They need to use a national change of address database. That's the one thing I know that many states are very concerned about, is having updated contact information to actually do the outreach to individuals who may need to be redetermined, and then certainly for those individuals that are no longer deemed eligible for Medicaid. They must also, states must also provide a report to the federal government to provide information about what is happening and how that is going. And then certainly there are enforcement and corrective action provisions included in that legislation. So with that, I just wanted to provide a visual of actually what that looks like relative to the key dates and policies. So you'll see here, states could begin their unwinding or their redetermination processes to internally determine who may or may not be eligible beginning as early as February the 1st. They cannot terminate coverage until April 1st, but they could start on February 1st to do that internal analysis about who is and who is not eligible. If they started on February 1st, those states needed to provide a report to CMS on February the 1st about what that plan is. If a state started after that, their deadline for providing that report was February the 15th. So there should be some good visibility in terms of states' work as it relates to this. The other dates up there were ones that I just mentioned as it relates to the leveling down of the FMAP. And then I would also just note a couple of the links there at the bottom that do provide some good resources from CMS that talks about the different dates and what that looks like and what states should be aware of. Understanding the impact. One of the things that we have been spending a lot of time focusing on is certainly during this unwinding process, there will be a number of individuals that are no longer deemed eligible for Medicaid. And so trying to understand where those individuals can find access to health insurance coverage. This is a high-level number. This is numbers that came from the Urban Institute that really shows that in most instances, most of the individuals that will be transitioning off of Medicaid have the opportunity to transition into employer-sponsored coverage. I will tell you, at least from my personal perspective, this was a little bit of a surprise to me. But we knew that individuals would have access to employer-sponsored coverage. The numbers then after that, you will see that they're still anticipating a pretty high number of uninsured, individuals going to the CHIP program, and then individuals being able to purchase in the individual market, whether that's in the marketplaces, in the subsidized marketplace, or just in the individual market. The one thing that we just actually, AHIP released just yesterday, and there's a link there at the bottom. We thought it was really important not just to understand this from a national perspective, but to understand with some visibility what may be taking place in your individual states. Again, for a source of support as you are working with your Medicaid agencies, with your governor's offices, with your insurance commissioners, and quite frankly, all of the provider stakeholders on the ground, patient advocacy groups on the ground, employers on the ground, to really understand where they may have access to coverage. Again, as I said, the modeling that you just saw there, once it winds up, it indicates that most individuals will be able to transition to employer-sponsored insurance coverage. And you'll see there it's really slightly under 50% to slightly over 50%, depending upon the state. Let's move now to the end of the national emergency and the public health emergency. So while we are focusing certainly on the decoupling that's happening and the date of really April the 1st in Medicaid redeterminations, we do now have a date certain for the end of the national emergency and the public health emergency. The administration has announced that it will end on May the 11th. They have formally made that announcement. They're linked and has also recorded it in the Federal Register. So essentially, what does that mean? As the federal government and as we all across the states are moving back to a return to normal, there will be a number of impacts. I know a number of these impacts we talked about, I think, at one of the very initial conversations that we had about Medicaid redeterminations, because that was one of many changes that took place during COVID. But you will have things because of waivers that states took advantage of, waivers that the federal government provided across different markets, And you'll also have things that took place in individual state Medicaid agencies, whether they did that by state plan amendments or other kind of waivers and flexibilities that they took advantage of. Again, really the purpose is to understand that there are likely changes in front relative to COVID vaccinations and testings and treatments, telehealth services. The emergency youth authorization, which many of you know gave the federal government and the FDA the ability to quickly move through products that were needed during COVID. There are also elements of this that won't change, and this emergency youth authorization is one of those areas that will remain the same. The PrEP Act, which or the PrEP Authority, which would really provided immunity from legal liability, was another change that took place. And then, as many of you know, there were many changes and flexibilities given to healthcare professionals during COVID. So again, the resources are listed there, and I think that is my last slide.
That was excellent, Miranda. Thank you. To the committee for questions. Go ahead.
We have new microphones, sorry. Miranda, good to see you. When we had this conversation, I don't know, last year, it was concern about the amount of people who were going to be dropped off the Medicaid rolls because municipalities weren't prepared. And there was a date, there was supposed to be an end date, and then they moved the date again. So just trying to get some clarity as to the numbers that we expect will be dropped from the Medicaid rolls. And I know some people aren't eligible anymore because maybe they're working now and they're not eligible, but a lot of people are transient too, especially low income, that they've had a lot of movement, during COVID. So what has been the expected number of people drop off, but what has been the directive from, I guess, the feds to states as far as getting themselves together in order to make sure that they are identifying all of the people to make sure that if they need the insurance, that they're getting the insurance? Because they can't have back coverage for people if they get dropped off. And isn't there a certain waiting period before they get on again? And that's concerning.
Yes. So all very good questions. As you indicated, the number of individuals that will have to go through this process is significant, right? Because they haven't done this in over 3 years. The estimates that we've seen in terms of individuals that will lose Medicaid eligibility is really anywhere between 5 million to 17 million. And those numbers obviously have adjusted. As I said, just last week we saw the new $93 million number. So absolutely a significant number. States are very aggressively so states have been planning, to your point of, how do they get in front of us? How do they make sure that they are reaching out? How do they make sure they've got the right contact information? Because that is really going to be the key. Being able to contact the person at a right address and really getting that person to do what they need to do to maintain their eligibility. So there are, many different things happening all across the country in a variety of ways, using best practices from one state to another. Again, making sure that those plans are very thorough, that they look at making sure that they are moving through the population in a certain number per month, so not doing too many too soon. Also, really another way that states are looking at this are looking at it by maybe doing their redeterminations by population. So maybe taking the individuals that they think are going to be ineligible first, and then moving through to other populations. I will tell you this workforce sort of concern that I know here all across this country in many different businesses is very true in state government, and it is very true in Medicaid agencies. And so there is a concern. In many states, this actually happens at the county level. So in Ohio, for example, there's 88 different counties that may be doing this, so it doesn't always wind up to one agency. as a result, I would sort of say it is incredibly important to, one, making sure that you're working across agencies, right? This, I think, originally sort of surfaced, and there was a lot of thought that this was just a Medicaid issue, right? But when you look at these numbers and when you understand that a number of the individuals actually could move to employer-sponsored coverage, this is a insurance issue, this is an employer issue, this is a provider issue to make sure that providers today that have a reimbursement resource tomorrow have a reimbursement resource. And so there is a lot of work, there's a lot of sharing across of best practices. One way that I know that as health plans, we are really standing ready and trying to help states to try to fill some of that workforce gap that is existing in state agencies. And, health plans in many instances know where the members are better than the states. Our data is more up to date. And so to the extent that you can work with your health plans in the state is really helpful. But a lot of planning underway.
Miranda, thank you. We have some more questions. So we have Workers' Compensation Committee in just a few minutes. So we have 4 additional legislators that will ask questions. If you keep your questions concise and the responses concise, we'll all be happy. So let's go to Senator Hackett.
Okay, yeah, I appreciate it, and thanks for your question. I mean, her question was one of my 2 questions. And remember, we all know about the cliff effect, where people can come off Medicaid, phenomenal coverage, and then have less, even though they're getting higher incomes, which came through COVID because of the demand for workforce, et cetera. We see, the question I have though, we see in almost all the states, we're having a huge increase in the number of Medicaid state employees. We're really seeing that huge in Ohio. In your mind, is that temporary? Is that a situation that won't last that long? It's because of this problem? And why don't our managed care plans, why can't they handle it? But we're seeing a massive request from them to have a massive increase in the number of employees in the Medicaid department, as you know.
So that does not surprise me, right? The workforce that's going to be needed to help with this volume, I think is absolutely true. And then to your second question, I would say health plans stand ready and are working very aggressively and deeply with the state agencies where they can and where they're given permission to do that direct outreach to enrollees.
Thank you. Thank you, Senator. Representative Rogers.
Thank you. Yeah, real quick, a couple things. One, I think there's some challenges that I've spoke with some of my health plans in my state because of HIPAA laws. They're prohibited from trying to reach out proactively. So I do think that the states have a big role in trying to help push this information out. And we should have been doing this, in my opinion, late last year. In our state alone, we have 400,000 people that this could affect. The other thing I wanted to uplift is I did not know myself this until I started diving into it a couple months ago, that there's the marketplace is significantly subsidized by the Federal Inflation Reduction Act, the IRA. So in my opinion, the other thing that is needed is navigators to handhold some of these Medicaid patients that are no longer eligible, because there are products and they may be very cost effective. They may be $10 a month, whereas before the products were just so cost prohibitive that they wouldn't look at them. So I think getting the word out with digital toolkits, as well as having some hand holding to have a soft landing for these folks to go, I think is critically important. Thank you.
Thank you very much. Representative Ferguson.
Thank you, Mr. Chairman. Is there anything in place from the health insurance plans to help smooth this transition? I mean, I worry about patients. Say they have a prior authorization for immunotherapy or medication and all those kind of things. Is there some process to sort of smooth those people from Medicaid to an insured plan where they don't have to immediately change providers or get a new prior authorization and have a gap in their care?
So great question. And as you probably know, in many states, the Medicaid managed care plans also have a product on the exchange marketplace. And so that is a place where if there's an opportunity to move somebody who is ineligible on a Medicaid in Medicaid over to the exchange marketplace, where they might have the ability to receive subsidies, where there can be that continuity of coverage, to really help with that.
Thank you. And our final question will be our Vice Chair, Representative Carter.
Thank you very much, and thank you for the presentation. My question is, you mentioned that 50% of the people will go into some employer-based insurance. I'd like to know, how would they be able to get that insurance if they are not employed? Many Medicaid people are on Medicaid because they can't get a job.
Yeah, so that's a great question. Many of the individuals that I'm speaking to are those that have remained on Medicaid throughout COVID, and they may have gotten a job. They may have gotten a promotion in a job or gotten different kind of job. And as a result of that change in employment that has taken place during COVID, it would provide them access to that employer coverage.
Follow-up question, sure, Mr. Chair, if you don't mind. And the recipients who didn't get a job, what is their recourse?
So certainly the individuals that don't, hopefully there is an opportunity for them to purchase affordable health insurance coverage through the marketplace, through the additional subsidies that have been extended through the Inflation Reduction Act. And so that certainly is another strong opportunity for them. What we hope is that individuals won't become uninsured. We know that that has a significant impact not only on that own person's life to not have access to health care, but it certainly has an impact across the health insurance, health care market for employers, for providers, where you have a higher percentage of uninsured.
Thank you. Miranda, you can tell this is a very interesting and hot topic for us. Thank you very much for your answers. If you'd like to take us all to dinner tonight, we could continue the discussion. And to all of our panelists, thank you very much. Before we adjourn, let me just mention that our intent is to take a quick 2-minute break and then go right into workers' comp, and it's intended to be just 2 minutes, so we have a very tight schedule today. Who would like to move to adjourn? We have a motion to adjourn. Is there a second? Second? All in favor say aye. Opposed say no. Motion carries. We stand adjourned.